Imagine having a full team of doctors, therapists, and caregivers supporting you at home with no copays, no insurance battles, and no confusing networks. Sounds impossible? It's already happening. Let's talk about it.
Welcome to From Leads to Leases, a CCR growth podcast that helps senior living providers transform their complex challenges into opportunities. Listen in for stories from industry leaders, innovative strategies, and insights. And with our expertise, learn how to increase occupancy faster, guaranteed.
Welcome back to another episode of From Leads to Leases, the podcast that dives deep into the senior living and senior care industries, bringing you insights, strategies, and stories from the experts at the forefront of innovation, leadership, and care. I'm your host, Jerry Vinci, CEO of CCR Growth. And for those of you who don't know about us, CCR Growth is a full-service marketing and growth agency that's exclusive to the senior living industry. Through this podcast, I'm here to guide you through the evolving landscape of senior care, exploring the innovations, the strategies, and leadership insights that are shaping the future of the industry. So whether you're a provider, a caregiver, or an industry leader, this show is here to help you make informed decisions and create meaningful impact. Today's guest is Henriette Kole, a healthcare leader who has worn many hats: occupational therapist, nursing home administrator, and now an advocate and champion for PACE programs across the U.S. Through her company, DLK Care Associates, Henriette is helping providers launch PACE programs, a model designed to keep older adults living safely in their homes while receiving full-service coordinated care. So in this conversation, we're diving into what PACE really is and why more people need to know about it, how PACE programs are solving some of healthcare's biggest challenges post-COVID, why aging in place is no longer just a dream, but a growing reality. So Henriette, welcome to the show. And let's get into it. We got a lot to talk about.
Okay, thank you, Jerry. I think it's important to just give a little perspective of the amount of older individuals that there's going to be. So in 2030, there's going to be 71 million individuals in the United States over 65, which is a daunting number and quite a big increase in what there is now. Our current healthcare system is already strained with very, older models of care, institutional models, home care, trying to cover very large areas, and assisted living, which generally are not large programs. So one of the challenges, not only since COVID, but in general, is number of population and number of workforce population, which also seems to be declining. So a PACE program provides the opportunity to be more inclusive in many ways. Although in the past, it used to be seen as sort of a boutique program, a smaller program, it really has the capacity for hundreds of individuals, not only because there are not strict requirements about attendance, where you have to be, exactly what you have to be doing, but also because within counties, you can have smaller programs that use that larger program as a home base. Let me just talk a little bit about PACE in general. So the program of all-inclusive care for the elderly started actually on the West Coast, and it grew out of communities of international workers that came to the United States for projects like the railroads, mining, and aged here, and were groups of older men living in a community type setting who needed all kinds of services, and was eventually coordinated into a social and medical setting. So through the 80s, through the 90s, and now currently today, it's a well-known accepted model and receives a lot of accolades for the coordination of care. So what does that mean? It means that there's a PACE center where individuals could attend. You can get all your services at home, because some individuals aren't that social.
Sure.
And then you have home care. Wherever you call home, you can receive that home care. It's supported by the federal government and the state governments. So what again makes it very unique in today's healthcare world is that you receive a capitated payment for each individual. And that means that Medicare and Medicaid are both putting money into your pot, giving you one rate, and your requirement is to assume full risk for that rate. So if they give me $5 to take care of you, that $5 is everything that you need, from hospitalization to meals to socialization and et cetera. So you need to be able to manage the things that we want to manage, keeping people out of the hospital, keeping people out of the emergency room, making PACE and the staff their destination or choice for information. So it's a big, it's a little bit of a learning curve for the clinical staff. They forget that the biggest benefit is that PACE is the payer and the provider, and the only such program there. So sometimes it's hard to have clinical people learn that they can say, no, doctor, we're not going to do that. It's very expensive. And our team, who knows the participant very well, doesn't feel it's something that would really be beneficial to our care plan for that person. And that is, one of the simple ways to control the cost. And that happens a lot in the emergency room. They, can admit the patient and run a whole battery of tests. Why? They're 92. Is that really necessary? So that is a place. So you're managing your risk because you're not going to pay for a very expensive hospitalization. And actually, you're really managing the participant because you're protecting them from the hospital environment, the potential for infection, and just the social aspect of being an elderly person in the hospital that nobody's really paying all that much attention to unless you're in crisis. So that, overall, that's a good way to look at PACE.
Yeah, oh, that's a great overview. And back to what you were saying too about the number of adults over the age of 65. This is kind of a crazy time because we have the number of adults over the age of 65 that's going to increase and increase. And then housing demand, right, is going to go up with that. I think by 2030, the housing demand is supposed to double. And then by 2040, it's supposed to almost triple. So you've got that number going up. But at the same time, you've got development and construction in a downward trend. And so I would think PACE is going to really take hold because there's a lot more people who are going to look at aging in place and who are not going to want to try to move into a community. Number one, I mean, a community is not for everybody, but number two, because there may not be enough availability. So we may have to look at options like this more than in the past. I mean,
Well,
what do you think about that?
I think we have to be a little bit more understanding about what people call their home. We're always trying to take people and put them where we think they should be and
Yeah.
then give them what they need. And the truth is, especially where I am in New York and close to New York City, people have very different home environments. And that's where they want to be. And that's the neighborhood they know and their own informal social supports. So you take these individuals, you put them in as you say, a big housing project, and I'm not sure how that really benefits them. They're not unsafe. If you're talking about individuals that are unsafe, that's very different. But what this is focusing on is giving care where they live and making them feel secure where they live and not so lonely. Because as you know, lonely and depression, especially post-COVID, is rampant. Even if they went out a little bit before, the level of anxiety, I think, is very high, especially for older people. And there's needs to be so much training, and sometimes we can't find the staff to train it. So it's definitely a challenge. Now, each state has different regulations. So the federal regulations are the same for everyone. They're federal regs. But the state either can make it very simple or a little complex. New York's my favorite state, but it's a highly regulated state. So just to get through the application process can be, a little daunting, and it doesn't make it as user friendly to say, hey, let's do this, because you have to have people, individuals. And one of the reasons why I started my company was to support individuals and say, you don't get overwhelmed by all that. You're just going to use what you know. We're going to answer the questions. Maybe there are a lot of questions, but there's also a big financial piece, because the insurance piece of PACE is, I think, in many regulators' minds, they think of the big insurance companies. So they're looking for big numbers of expenses, and you're going to spend this. These are providers who've been just making it, or making it by, advocating for their Medicaid rate, advocating for their other opportunities to increase their revenue. So in New York, it's a little bit of a challenge right now. We're all very hopeful that there's going to be a new process that will allow people to really come into New York. And there's a lot of groups that want to come into New York. And certainly there's a lot of people. We've got to just make it a little bit easier, I think.
If someone wanted, I mean, I don't know if somebody can do this on an individual level, but say, for instance, my area, there isn't a PACE program directly in my local area. What would it take to get one integrated?
So I'll talk about New York, although I do work with several people from California. I think it's a little bit easier in California, but primarily what you need to do is identify your service area, which is generally a county. And although if it's a county like Brooklyn, where it could support two or three programs, let's just say you need to say, this is the county I want to operate in. This is the market feasibility we've done. So this is the number of elderly individuals. These are the numbers that receive Medicare, Medicaid. And remember, PACE is 55 and older. So there are Medicaid only individuals. And then you notify your Department of Health that this is your intent. And then you start an application, just like any other application. As I said, in New York, it's very lengthy. And it's lengthy because you have to become a managed care organization first in New York. You can't just say we're just going to be PACE. You have to become a managed care program, then you're going to apply for this. So it does make it lengthy. But frankly, it's two applications. It's your state application that then says you've met all the criteria, you've answered all our questions. Now we're going to push you over to the federal government, to CMS, and within their electronic system, you answer their requirements, your organizational structure, and do you have enough staff, and how are you going to measure quality, and how many people do you expect to enroll? Those are the primary questions.
Okay.
And so it's really not terribly complicated, but it can be complicated by outside forces.
You mentioned too about isolation, and I know we've seen a greater focus on reducing isolation since, well, post-COVID. How does PACE specifically address those growing needs?
So I saw an ad yesterday that said loneliness is right up there in the negatives with smoking. It was really an interesting article about the effects and the damaging effects. Again, I'm going to say, well, California is very similar. You have communities where people are not, well, fluent in English. They need the support, are very timid or afraid to ask how to find that. The depression and loneliness in elder people I think it's very much downplayed. People come out and they put their lipstick on and they're dressed and they come one day a week and you think they're doing great. But then you go to their home and you see there's nothing in the refrigerator. The kids that are supposed to come and pop in and take care, there's not a lot of clothes there. And the loneliness takes on so many forms. They feel isolated because their language skills are not good. They feel isolated because they don't really know where to go. And then again, there's a fear factor of, what am I going to experience? What are these doctors and nurses going to do, to me? So I think that outreach and a relaxed environment, in PACE, it's called a life plan, not a care plan. So I think if that's your mentality, we're going to see you Monday through Friday. What are you going to do on Saturday? So we have all these clinicians giving you, we're going to keep you at this, and you're going to weigh this, and you're going to eat this. And we know that, come Saturday,
Yeah.
they're going to do whatever they want. So you do things like shopping in a bodega, for example, in an area that's very Latino, and say, listen, instead of buying this, buy this. It's a little better. It's not as full of salt. Let's be realistic about what we're doing with your life. And I think that's the same thing. They develop relationships at home with their caregivers, much more likely to let them in and talk to them because you're not rushed. You have the time. You have lots of people's input saying, remember, be sure you're talking on her right side because she really can't hear well on her left side. That kind of stuff. So I think all of that is sort of magical in making the connection with the individual and does definitely is this help with loneliness.
Even just someone being in their own home, they're much more likely to open up and feel more comfortable engaging with somebody than if they have to go somewhere else and, like you're saying, feel rushed for time. So that makes sense. How do you feel about technology being an isolating factor for older
Actually,
adults? Yeah.
I actually wrote that down. So there is definitely more technology being used. The younger, older adults, let's say the 60s, people in their 60s and 70s, are much more likely to be open to an iPad or, in many cases, robots, which we have now, and all kinds of things. They understand how to turn a computer on. They're not frightened by it. Older people still a little more challenging. And then the one thing that I always remind technology companies is they don't have Wi-Fi. They're not paying for, they're using a pay-as-you-go phone. They're not going to use their $10 on you. Like let's understand where we are and what's going to work. So there's a lot more technology around, even in institutions, which helps waiting times. And you pick up an iPad and see your doctor who says, I'm going to be with you in about 20 minutes. Relax. Everything's okay. Just got a little backed up instead of sitting there not knowing what's going on. And the same at home. If you or your caregiver can press a button during the middle of the night and say, I really am having trouble breathing, but you're watching them, you can see, is it anxiety? Is it really a breathing difficulty? And those are the things we hope that are going to make very strong clinical outcomes that aren't just everyone rushing to the ER, because they got nervous or their caregiver got nervous. And many times it's the caregiver. She doesn't look right. We better get her to the ER, that kind of thing.
Mhm.
So being able to reach your team with a tailored telehealth device that you only have one button and that button's getting you to whoever's available on your team and you're immediately seeing that person, in many times it takes the anxiety way down. And you can say, well, remember when you felt this way? This is what we did, and it seemed to be helpful. I think it's only going to be more and more utilized because it's becoming so much more familiar. But in this article I read about the population, they said it's much more successful because people in their 80s aren't as open to using technology as a lot of the retirees who are 70, which today is very young. And they're used to technology. They know how to use their bank card. They know how, so there's a lot of references. I think it's going to go a long way to helping people access a provider a lot simpler than calling and waiting.
Yeah, I think the generations vary so much too when you look at isolation and what we consider engagement and companionship, right? I read a statistic that said at the age of 65, the average person spends about 6 hours a day alone. And then by the age of 80, they spend over 10 hours a day alone. So that's a huge shift
Huge.
as your circle continues to get smaller as you age,
Correct.
But I think my generation, for example, we can connect somebody through a screen and feel some level of
Right, right
companionship.
there.
Yeah. But I don't think that's the case for some
Now.
of the older adults out there. So I think that's part of the isolation challenge too. Because we're sitting here, I could FaceTime mom, 3 times a week and be okay with that. But she's like, if you're not here, I still feel alone.
So it is definitely how it's received. And there's so many older people who have lost they're the last one standing, and they are not that interested in making new friends. That makes them too nervous, or we did have success during COVID with doing games on the computer once we could get people, word games, number game, or who remembers the capital of Texas kind of thing. But more and more people by the end, we had about 60 people one day that would call in just to get to do something, just to do something. And that way, the team got to sort of look at everybody and say, gee, she looks a little thin, or she doesn't look like she's sitting up well. Let's send someone over there. So it was a good way once we were successful, and it did take a while. I mean, COVID was terribly challenging because the centers closed. It was very hard to get doctors to make house calls just because of the demand. But
Sure.
it really became a house call program, and that's requires an awful lot of individuals.
What would you say are some of the biggest misconceptions you run into when introducing people to PACE programs?
Well, if you know a PACE program, if you have some knowledge of PACE, the early regulations made it very rigid. You had to use a PACE doctor, you had to use the PACE network. That has relaxed very much over the years. You can use your community doctor. The PACE program will form a relationship or a contractual relationship. So a lot of that has loosened up the ability for people to say, oh, I don't want to do that. Then I have to give up my doctor and give up my. So that's helpful. Also, they hear it's an insurance company and they want to jump out the window. They're like, oh no, I don't know. I'm not interested in another insurance company. So we have to be sure that they understand that we're going to take care of them. And we are now their Medicare and Medicaid. They're going to get a card with our PACE Center's name on it, and they can take that anywhere they want to go. And once they start to understand that, because they don't know, do I need this now? Are you my Medicare, or are you in addition to my? And I always used to make a joke as my mother aged. We knew that she talked to somebody in the supermarket. She would have a new magnet on her refrigerator. We'd be like, oh no. Then she would disenroll in one program and be enrolled in another.
Yeah.
And she would say, oh, they were so nice, pens and paper and bags, giving older
Yeah.
people bags. Forget it, forget it. So, I think that once that understanding is there, we're a care team, we're going to take care of you. You don't have to worry. There are no copays in a PACE program. You don't have to worry about how much is this drug going to cost. There is literally nothing that the PACE capitated rate does not pay for. Only one thing, rent. You can't think of anything else, nothing else. Transportation, taking a ride to visit a friend at a hospital, arranging for your pet to be taken care of if you're put in the hospital. All those things that make people not want to leave or address something.
That's pretty awesome. I was watching that video earlier today, just familiarizing myself with the overall costs associated with PACE, and it was saying something along the lines of, in certain situations, the family would be responsible for the premium for PACE if they didn't qualify for certain things. What would that cost look like if that was the case?
So they're not responsible. So what happens is when a program accepts the capitation, you sign a contract with Medicare and Medicaid that you're going to receive this rate for them, and the patient is never going to see a bill. Now, when patients get explanation of benefits and all that mail you get in your mailbox, it takes a while for them to realize this isn't a bill. They're just explaining to you what we've paid for. And I think the easiest and best way to get people to understand is saying you don't have to pay any copays when you go to the doctor, when you pick up your meds, when you get on an accessoride. It's arranged. It's scheduled. You'll be told you're being picked up at 11 o'clock. That's all you have to worry about, being there. Or we'll get you there. You don't have to go digging in your purse and worrying about, maybe I won't go because I really don't know what it's going to cost. So that is something that we're continually reinforcing. Nothing, no out of pocket. We'll bring you groceries. In the summer, we carry cases of water up those old walk ups. And, be sure that they understand you're not by yourself. We're here.
Because of that, do you see a lot of people relocating to areas that do have pay? I mean, in your case, you're in an area that supports it, but for me, there isn't one here.
Right. And
Yeah,
in California, they're opening like crazy. I
yeah.
mean, I know several just opened in San Diego. I think that once it's better known, and which is what we're all in my company and several other startup consultants are trying to do, is get the word out. And once people know, because look at the rural areas in the Midwest and in the northern just to get to a center could be an hour and a half ride. And where's the workforce? So these are the biggest challenges, getting people to that area so they know that if it's snowing and you live an hour away from everything you can think of, someone's going to get there. Someone's going to get there. You're going to get your insulin. We're going to take a look and see if you're really okay. And that's word of mouth. It's it's newspapers, it's the media, it's social media, which we do a lot of. It's familiarizing people through LinkedIn and other businesses that'll say, gee, we're a really big banking business, and everyone here has parents that are elderly. Will you come and talk to us? Those are the kinds of ways that we want to, reach out. There's a big association in Washington called the National PACE Association, and they are doing a very good job of getting to the legislatures, getting to the governors, getting the words out, that policy piece, having policy days, so that providers, such as myself, can say to you, well, why didn't you vote for that? Like, do you understand, like, what really, and truthfully, they don't, to them, in many cases, healthcare is healthcare. If it's Medicaid, it's all in one bucket. You're just asking for more money. So it's definitely an educational, a learning curve for a lot of people. But the more of us there are, and there are a lot, there's 12 or 13 programs waiting to get opened in New York. And I talk to people from California, Wisconsin, Georgia every day. So some of the states are making it very easy. And I think the more people see and hear and have a friend whose mom is gotten taken care of now through a PACE program, it's going to spread that way. It's a little informal for 2025, but I think that's the best way it's going to happen.
Is the program geared more towards individuals and families who are struggling with the affordability of all those different levels of care, or would it just be for anybody over the age of 55 who qualifies?
So it's a good question. It's actually, so the eligibility is you have to sort of look like a nursing home patient, like you have some chronic diseases. And what does that mean financially? It's usually borderline people. Those people have worked all their lives, have their savings, had different plans for it, and now need this kind of coordinated care. So you can enter privately, spend down your funds, which people don't like to hear, and then you're eligible for everything. Or you can pay privately, which is, I don't have to tell you, at least on the coast, it's almost prohibitive
Yeah.
and scary because people think, well, then I'm not going to have any money for anything. Well, we're not going to take your Social Security, but still, yes, if you have money in the bank, you're not eligible for Medicaid. So you have to walk them through that piece because you can't partially join. You have to fully join.
Um, a lot of people think that the PACE programs are kind of small and limited, but they're actually designed to scale and serve large populations, right?
Very large.
Yeah. How did that misconception come about, or how is it different?
I just think it's lack of knowledge.
Yeah.
It's never been limited by size, but because it wasn't well known, people weren't familiar, they remained small. Now, again, on the coast, like Unlock in San Francisco, there's some large programs in New York that have 5,000 members. And, different centers, they can go to different, they're called alternate sites, which are small, like a senior center or a social day center, where people can go still be part of a larger program, but
Hmm.
they don't have to travel. Actually, there's a lot of limitations on travel. You can't have someone on a van for more than 45 minutes or an hour, which you understand. It gets to be, a lot. But I think the only reason why programs are small is because people weren't familiar. And also, I think they heard insurance. It's an insurance company. No thanks. No, not interested. I think that does play a role, but I think that's gone away now. They see Pace as a provider. Nobody leads with insurance. It's just that we make it really easy for you because you don't have to worry about it. Like my mother, she would get as long as I gave her stuff, she was all in. She didn't care if it was an insurance company or not. But people are much better acquainted with options that are around, now.
Hmm. And what do you think are the biggest barriers to expanding PACE more quickly across the country?
I think the barriers are overregulation. Don't make it so complicated. It's not that complicated. Yes, it has to be regulated. Of course, there has to be high quality, but you can't make it so it makes people say, how am I going to get people that know how to do this? It's not that. And also, the fee to enter in some states is based on an insurance company mentality. So, what happens if you go out of business? What's your solvency number? What's your reserve number? And you tell providers who are taking care of old people in Queens that they need $8 million to sit on the side, to protect the program if you should go belly up. Well, if you look at the PACE model, only 6 programs have ever gone had a problem and since 1980. So that's a pretty good track
Wow.
record.
Yeah.
But I think that it has to just be an easier entry for providers that are upstanding in the community and already take care of lots of people. These aren't new people who decided they didn't want to run a clothing store anymore. They thought they'd do this. These are people that have years of experience taking care of people. And I just think it's going to take some time, like everything else. But clearly, the outcomes speak for themselves. The reduction in hospitalizations is huge. The reduction in people wandering away from their home, all the devices to keep people safe. Everybody's on board with those. The police, the community, the fire department. If we put out a silver alert now, just like an amber alert. So if a silver alert goes out in a neighborhood, everybody's looking. So it's really getting the word out.
I think that's a great point too. That's you can't this isn't something you could just start up out of nowhere. Like I was reading Malcolm Gladwell's The Revenge of the Tipping Point, and he's talking about the all the Medicare scams that happened in the 80s and how, doctors were just charging like
Oh,
900, twelve hundred
right.
dollars for a walker, like these crazy prices just to
Exactly.
yeah, that's insane. So that's great to
Exactly. And
know
there
that that
still
can't
is that
happen.
mentality that
Yeah.
that you're selling healthcare, but you really have to get on that right away and say, we're your team. We don't, we're going to take care of you. We're not bringing you things unless you need those things. So it does take show because of course that's how people got into everyone's homes. New socks, new special blankets, new special, I actually got a call from Medicare the other day and they were trying to sell. I said, "Are you kidding me? What?" And they were like, "Well, we see you have these diagnoses," which I didn't. And I was like, you should stop calling. And then I have to lecture them. You should really stop calling older people and doing this. And they just hung up on me. But, there's still a little bit of that out there. But I think the providers are getting ahead of them, which is a good thing.
With your company too, DLK Care Associates, I know you're working on finding providers and building partnerships for new PACE startups. What makes a provider a good fit for launching a successful PACE program?
So their philosophy and their mission. has to really be aligned. You really have to want to make the effort, big effort. You have to have staff that's interested in, I can see them in the clinic or I'm going to go to their home. I'm also a therapist, so you can see people at the center or all the therapists can do their treatments at home. So what makes a provider interested? Number one, of course, it's enrollment because all these other programs are constantly getting whacked with Medicaid cuts, Medicaid. So you're always holding your breath. There seems to be a little bubble over peace right now that they say it's going to move forward in a positive way. And I think that's because it's not a single payer. So it's not looked at under the Medicaid in that big Medicaid bucket. Um, but I think a provider needs to really want to. They want to grow their organization. They want to reach more people. They want to be responsive to their patients who are saying, that the two ladies on the first floor, they're very confused. So you really have to be invested in what you're doing. You have to be a sort of a we call it, a real old-fashioned healthcare person that's just got a heart that's too big. You got to want to. You really got to want to. Yes, it's a business. People are doing great, but in order to sustain it, you have to have really committed people because it's a 24, you're open 24 hours, 7 days a week. You never are not available. Someone always has to be available. So you have to want to do all that.
Does PACE partner with in-home care agencies or senior living providers, or would you say this is
Yeah.
more like the third option that people have?
No, so in order to be a PACE, you have to be three things, right? You have to be a clinic. So in New York, you have to be an Article 28 clinic. So you can do that in a partnership. Home care, you're partnering with home. You don't have to have your own home care program. You have to show your proficiency with home care, but it doesn't have to be your own healthcare organization. So it lends itself to partnerships, which lends itself to bringing more people in. And as long as you can say, we'll take you to the doctor, you're going to have positive outcomes because otherwise, most people aren't going to the doctor. And I just want to say also that one of the things I like to see myself specializing in are special populations, the developmentally disabled, the deaf, um, the blind, because when I started talking to some professionals that came to me from the Hearing Association, they were like, it's not that they have medical problems, but they need providers that understand how to, someone in the office could sign. Or then once somebody finds someone, everybody goes, right? Because at least they know they understand their particular challenges. Same with the developmentally disabled. You outgrow by age specific benefits. So a lot of those individuals end up in those middle years, 40s, 50s. They're, you got to get older or you got to be younger. So it's a population that does very well with that. And because seniors are very nurturing. And originally people are like, oh, you're gonna mix all these kinds of people. It was the best thing we did. The seniors were feeding them and helping them, showing them, and it really looking for each other. Where's my friend? She's not here today. And sometimes she's alerting the staff. Oh yeah, where is she? So it was a very positive experience
Yeah.
with the people with developmental disabilities, and I think will continue to be, because I do think that a lot of them are just in group homes with watching TV all day. I mean, we got to do more for people.
Yeah, I had a guest on who runs or owns adult day homes, and she was talking about intergenerational work that they do and how beneficial that was for all the people that they work with. Yeah.
Right. I mean, and for the children. We do bring a
Yeah.
lot of grammar school age children that maybe don't have a grandparent that they've been able to be around because it's not that way. Life isn't that way anymore. But they come in and sit and draw or just listen or talk about their day that's fascinating to these older people and maybe kind of boring to their family at home. But, it's very good for both ages to learn how to be out in the world and that the world isn't a perfect place and not to be afraid of sickness and disability. And I grew up with a handicapped sister, and people were afraid when I was young. They didn't want to go near her. They didn't understand. And it was really just understanding. But I see that I always warms my heart when I see the kids come in around the holidays. Everybody's so excited and they hug people and all of those really human factors that make this such a rewarding program.
Given your extensive work in post-acute and long-term care, what can senior living operators learn from the PACE model and how might they collaborate more closely in the future?
I think they can, I think senior living individuals, so there's two kinds. There's the private kind, and they sort of got it. They a lot of activities. They want to be sure everybody's happy, but they're paying privately. Then you have the state-supported homes, and those are generally for a less economically affluent population. To be honest, we kind of push our way in there and say, so does a doctor come here? Like they just are, they're tailored services. They do what they're required to do. Give meals, give pills, make the bed. And that's the expectation. And we all know that people need more than that. So, yes, PACE is partnering with a lot of different housing organizations now. And some of those big, huge housing complexes. I mean, in New York, all those gigundo buildings. Who knows who's living there now? So we have a lot of patients in those buildings, and most of them have community rooms. So we can do an education day or give flu vaccines. During COVID, we gave, COVID shots, and we would just put flyers everywhere, under doors, wherever we could, and people would come down, and then we could at least see, wow, she get down here, So it's really got to be curious and interested in your neighborhood. And the providers of housing and big daycares and have to also think, well, what happens when this person goes home? Or what happens on Sunday? What are they doing all weekend? And in many cases, it's nothing, waiting for Monday.
I think there's definitely going to be a wider adoption of PACE programs in the next decade. How would that shift the senior living landscape, given what we talked about, the number
Mhm.
of older adults in the market and how that's going to expand?
I think that it's going to make this population boom feel a little bit more manageable. The more it gets out there that there are these kinds of programs that can take a large capacity, that can get to people's homes, that can pick them up in vans and bring them where they need to go. And these are all the regular obstacles, right? Well, we got to get them, we got to bring them here. Well, you know what? You got to figure it out. That's how I feel. There are opportunities to to figure things out. The thing I worry about now is the workforce shortage. There's just, it's really hard to find people. And people my age, my contemporaries, many of them are retiring. They've put 40 years into this. They're tired, you know. And so on both sides, you don't have a lot of, you have your experienced people dwindling, and you don't see a lot of people rushing to become a home health aide, although it could solve a very large employment problem. So there's so much to be told. There's so much of the story to be told that can help so many ages of people. But the more people we enroll, the more people we need to take care of. So I think that's probably among everyone's number one worry, finding
Yeah.
staff.
For sure. I, a recent statistic, I think, said there's like 880,000 long-term care workers now, and by 2040, we need over 20 million to provide care.
It's not even like you
That's,
can't even
yeah.
put that in
How do you wrap
volume.
your brain around that? I mean,
Right,
there's that,
right.
plus there's the education piece, there's the training piece, right? Just learning the basics of the job is one thing, but then learning about senior care and all the different nuances of that for all the different levels of care, I can't even imagine how that's going to be accomplished as well. So just the massive scale that needs to happen
Yeah.
here
And
is
I think
daunting.
that's a little bit of the part that scares people. You have to do background checks. You want to be sure people really are who they say they are. It's involved. But again, if the universities and the schools and if the community would come together on different platforms, I think all that stuff. I'm very optimistic. People really do want to help each other, and I think you just have to touch those buttons.
Absolutely. Absolutely. One of the things, and you touched on it a little bit earlier, but you talk about the danger of missing the hidden needs of seniors who appear independent. How can caregivers and providers do a better job recognizing who needs more support?
I think by paying more attention to who's living in their community. I mean, if I have a PACE center in the middle of Harlem, which is one that I just left, we have to get into those buildings all around the center and take a look. You know, you can put a desk in the lobby, you can have people sit with coffee in the morning and say, "Come have a cup of." The only way you're going to know is by looking and by people telling you, and they will. They'll say, "You should go to that 12th floor. There's a man there that is always hungry." You gotta be interested, but you gotta put yourself physically there. You have to look. You can't just say, "Well, nothing's really happening in that building. I guess they're okay," because chances are they're not. In the old days, you used to see all the Europeans hanging out their windows. Used to make fun of my background. It's Italian, so we used to say, "Oh, look, we can go to the Bronx and see who's okay because they're always sitting at their window." It's it's not life isn't that simple anymore. But I think getting into the buildings is really important. Knocking on doors.
We talked a lot about a lot of different aspects of PACE today. Is there one aspect of it in particular that you think our audience should know or that we didn't cover today?
I think the most important takeaway for PACE is that it's everything in one program. That it's not fragmented care. It's not you got to go to the doctor and then you got to go to the dentist and then because that just doesn't happen. So PACE actually gives you a team of people keeping an eye on your needs. Do you need glasses? Like, why are you reading that way? Or they have some very cool technology. There are floor tiles that you can't tell are different, but you can see on a screen the people coming in every day. Gee, look at that walking pattern. Something's going on there. So the more technology gets involved, the more people think a little deeper thoughts than just go to the doctor, go home, and look at all the things balanced that are going to keep people safe and home. I think you're not going to find a program better than PACE that's going to look at the whole person.
For those who want to stay connected or learn more about PACE or DLK Care Associates, where should they go?
I think LinkedIn is the best place for me, which is under Henriette Kole, my name. I'm working on getting a company website, which I will publish. And also first of all, people contact me all the time on LinkedIn, just even to be referred to someone else. So I'm very happy with that. And the National PACE Association, which is NPA Online, one word, .org. And you don't have to join to learn everything in the first 10 pages, including where you can get technical assistance or who you can contact in your state. And I think that's a good place to start. I'd like to say there's lots more out there, but I'm sure there will be in the next few years because there's a lot of us now pushing and getting startups open and doing a lot of marketing and advertising and getting a lot of TV producers interested.
So I'll make sure to include that in the show notes and your LinkedIn
Okay,
profile so people can reach out.
right.
So thank you so much. What
You're
a great
welcome.
conversation. I appreciate it.
You're welcome. Thank you.
Yeah.
Helps me also
Yeah. Oh, this was
get
great.
the word
This was
out.
great. As we wrap up today's episode, I want to extend a huge thank you to Henriette Kole for joining us and giving us a behind the scenes look at the power and potential of PACE programs. Your advocacy for aging in place and patient centered care is both inspiring and incredibly timely. If you want to stay connected with Henriette and learn more about her work with DOK Care Associates and PACE program expansion, we've included her links in the show notes. So we hope you found this episode insightful and inspiring. Don't forget to subscribe to our podcast on your favorite platform and stay tuned for more episodes where we continue to explore the evolving world of senior care, from marketing and sales to innovation, leadership, and the human side of aging. I'm Jerry Vinci, CEO of CCR Growth. Thank you for joining us on From Leads to Leases, and please like, subscribe, and share this episode with anyone who might find it useful. I'm grateful for your time and attention, and until next time, lead with strategy and with heart. Chat with you again soon. Thanks, Henriette.
Thank you, Jerry.
Thanks for listening to From Leads to Leases. Are you ready to fill your rooms faster and increase occupancy? Visit ccrgrowth.com to learn about our Senior Growth Innovation Suite, a proven system to generate highly qualified, tour-ready leads, accelerate sales, and reduce acquisition costs. Let's connect and turn your challenges into opportunities. See you next time.